On behalf of the American Heart Association, I would like to welcome you to today's webinar, Best Practices for Integrating Diabetes Care and Managing Cardiovascular Disease Risk in a Health System. My name is Renee Sednew, and I'm a manager in Quality Outcomes Research and Analytics with the American Heart Association. To begin, I'd like to go over a few items so you know how to participate in today's event. If you would like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. At the conclusion of today's presentation, you will receive a link to access today's recording, as well as an invitation to complete our feedback survey. We welcome you to submit text questions for our presenters at any time in the questions pane of the control panel. We will collect your questions and address them during the Q&A session at the end of today's presentation. The American Heart Association and the American Diabetes Association, along with industry leaders, have proudly launched the groundbreaking collaborative initiative, No Diabetes by Heart, to reduce cardiovascular deaths, heart attacks, and strokes in people living with type 2 diabetes. This initiative seeks to comprehensively combat the national public health impact of type 2 diabetes and cardiovascular disease. Cardiovascular disease is the leading cause of death and a major cause of heart attacks, strokes, and disabilities for people living with type 2 diabetes. To focus on these critical type 2 diabetes patients with cardiovascular events, the AHA has launched the Target Type 2 Diabetes Initiative aimed at promoting evidence-based care for this critical population. Target Type 2 Diabetes provides healthcare professionals with resources and tools to address this urgent challenge and be recognized in a new honor roll for their treatment of heart failure and stroke patients with type 2 diabetes. Today, we will hear from two Target Type 2 Diabetes Honor Roll award-winning hospitals. Briefly, some AHA disclosures. AHA does not endorse any products or devices. The following content reflects these hospitals' best practices. It is now my pleasure to introduce our three speakers for today. Heather Harpster is a diabetes educator at Mount Nittany Medical Center. She is a registered dietitian, certified diabetes educator, and licensed dietitian nutritionist in Pennsylvania. She received her Master's of Science degree in nutrition at Case Western Reserve University and completed her clinical internship at University Hospitals of Cleveland. Welcome, Heather. Susan Maynard is the stroke coordinator for Mount Nittany Medical Center, a 260-bed acute care facility located in State College, Pennsylvania, that offers medical, surgical, diagnostic, and community services as part of Mount Nittany Health. In her position, Maynard is responsible for the coordination of stroke care across the continuum. She graduated from the Pennsylvania State University in 1996 and achieved her master's degree in 2010 from the University of California, San Francisco. Melody Halio is a dynamic nurse leader, educator, and pioneer in changing the outcomes of patients at Henry Mayo Newhall Hospital in Valencia, California. Over the last 10 years, Melody has contributed to positive patient outcomes in the intensive care unit and interventional cardiology cardiac catheterization lab. For the past 2 years, Melody has dedicated her expertise as the nurse navigator for the Advanced Primary Stroke Center and the diabetes program at Henry Mayo Newhall Hospital. And she was the first navigator in the organization to take on the role of leading 2 disease-specific care programs, and has done so with great success. Melody's passion for diabetes and safe patient outcomes has led Henry Mayo to a 30% reduction in medication-induced hypoglycemia and a 40% decrease in hypoglycemia events. Her commitment and dedication to this program earned the hospital their first Target Type 2 Diabetes Award. It is now my pleasure to turn today's presentation over to our first speaker, Susan Maynard. Susan, the floor is yours.
Great. Well, thank you very much for the introductions. Hello, everyone. My name is Susan Maynard, and as stated before, I am the stroke nurse coordinator at Mount Nittany Medical Center in State College, Pennsylvania, and I will be speaking today with Heather Harpster, who is the clinical diabetes educator for our hospital. Neither myself nor Heather have anything to disclose. So just as a bit of background, we are a 260-bed independent community hospital located in central Pennsylvania, and we are one of the few hospitals in our area that is not associated with a larger health system. We achieved primary stroke center certification through the Joint Commission in 2014 and have had successful recertifications every 2 years. In 2020, we received the Get With the Guidelines Gold Plus Award, Target Stroke Honor Roll Elite status, and the Target Type 2 Diabetes Honor Roll. To give you a bit of information about our demographics, we are located next to a large university that sees 60,000 plus students. We are also a retirement destination, and our service area covers 6 counties with urban and rural areas. In 2019, we had over 55,000 emergency department visits and had 457 patients that discharged with a stroke diagnosis. And Heather, I will turn it over to you.
Hi all, this is Heather. I'm going to spend a few minutes talking a little bit about our diabetes program here at Mount Nittany. So why did we at Mount Nittany decide to focus on diabetes care? As many of you already know, one of the main reasons, extensive research has shown that diabetes is associated with worse outcomes in hospitalized patients, especially in those patients with uncontrolled blood sugar values. Here at Mount Nittany Medical Center, diabetes is a co-diagnosis for approximately 20% of all of our inpatients, and diabetes is a co-diagnosis for approximately 38% of our patients who have had a stroke. Looking a little closer at stroke statistics, those with diabetes are at a 1.5 to 2 times greater risk of having a stroke as compared to people that don't have diabetes. And as already mentioned, cardiovascular disease is the leading cause of death for people living with type 2 diabetes. Also, post-stroke outcomes are poor in patients with uncontrolled glucose levels. And because of these statistics, Susan reached out to myself about a year ago, and we really met to kind of learn a little bit more about each other's program and how we could work together more to improve the health of our patients. So this slide just gives you a little bit more details as far as our inpatient diabetes care program here at Mount Nittany. We received our initial Joint Commission certification for inpatient diabetes care back in 2014 with successful recertification every 2 years thereafter. Having Joint Commission certification for inpatient diabetes care requires that we as an institution are really demonstrating our excellence and expertise in providing quality diabetes care and education to all of our patients with diabetes. To meet these Joint Commission requirements, there are a lot of things that we had to put into practice, and below these are just a highlight of some of the things that we put into practice here at Mount Nittany. Really just having an overall commitment to helping our patients achieve the best diabetes care. We follow the American Diabetes Association clinical practice guidelines for all of our order sets, our protocols, et cetera, et cetera. We look at those every year and adjust accordingly. Just making sure that all of our staff are familiar with, understand, and follow all diabetes policies, protocols, and procedures, from our hypoglycemia policy to our hyperglycemia policy, insulin pump and CGM policies, as well as all of our screening protocols for different parts of the hospital. Daily patient education on those diabetes survival skills, just making sure that our patients really know what to do in different situations when they leave the hospital. Making sure that all of our patients that have diabetes, that diabetes is part of their care plan regardless of their diagnosis. Starting discharge planning early, day one when the patient walks into the hospital, really starting to plan what may need to be adjusted or changed, if anything at all, at discharge, and kind of coordinating everyone to help with that process. We also do data collection. So part of the Joint Commission program, we collect 4 performance improvement measures every 2-year cycle, and then we report that data to Joint Commission on a monthly basis. And then also just ongoing diabetes education for all our staff. So I meet with all of the new RNs and go over a lot of diabetes basics, as well as things that they're going to be involved in the hospital. We have yearly HealthStream online learning modules that all of our staff do. So even those that are non-clinical, we have just basic diabetes education information for them to be aware of. And then just ongoing staff meetings on a monthly basis as needed. So this is the screening process that I follow every morning to identify those patients that just may need a little extra help with managing their diabetes. So consults, I can receive a consult from a physician, nurse, pharmacist, could be really from anyone in the hospital. We also have a RN admission screen that the nurse does with every patient on admission. We have a diabetes section in that, and I'll show you a little bit about that on the next slide, but anyone that would trigger on that screen, I would automatically see. I also get a list of the admitting diagnosis, so I go through that list, really trying to tease out anyone that might need a little extra help. So anyone that might come in with diabetic ketoacidosis, HHS, hyperglycemia, hypoglycemia, maybe a non-healing diabetes wound, anyone that just might need a little bit of extra help from a diabetes standpoint. I also get a list of A1C results every single day. So I automatically see anyone with an A1C over 9%, and then lower numbers as time allows. And I also get a list for A1Cs above or equal to 6.5 with no prior diagnosis of diabetes. So we're really trying to help identify any of those patients that may have diabetes and didn't already know that they had diabetes. So we're a lot of times diagnosing people here in the hospital. I also get a list of blood sugars. So anyone with a blood sugar less than 70 or anyone with a blood sugar above 300, I have a list for that. I really focus mainly on the admitting blood sugar, because I'm really trying to tease out those patients that may be having some difficulty managing their blood sugars at home. And if they come in with a blood sugar of 35, and their A1C is on the low side, that just might identify someone that might be having some trouble with hypoglycemia at home. This is our RN admission assessment. So the first 3 questions are really to help identify any knowledge deficits and those survival skills. So anyone that would answer no to these questions, it prompts the nurse to provide just basic education with the patient. We also have a diabetes packet that the nurse can provide to the patient, or they can also attach an education sheet that will actually print out at the time of discharge. So really just making sure that those patients get the information that they need that they didn't already have. Under identified education needs, these are the alerts that I get, and I would automatically see these people or screen these people to see if they need to be seen by the diabetes educator. So this slide just kind of gives an example of what my patient encounters sort of look like. Every single patient that I meet with, I just do a brief initial assessment. I will, how long they've had diabetes, what medications are they taking, what dose of medication are they taking, when do they take them, are they taking them every day? Also asking the patient about checking their blood sugar. Are they checking their blood sugar, how often they check the blood sugar, what are their results? And really the focus of my visit with the patient is really tailored to what brought them in. For example, if I have someone that comes in DKA, I'm going to spend a little bit more time trying to figure out what potentially caused the DKA. If it's a pump patient, was the infusion site kinked? What happened? Really spending time talking about sick day guidelines, making sure that they're checking ketones anytime their blood sugar's on the higher level or they're nauseous, vomiting, spending a little bit more time there. If I have someone with an elevated A1C, really just trying to figure out what is the cause of that elevated A1C. Are they missing their medications? Are they taking their insulin correctly? You know, how's their diet, exercise been lately? Recent steroid use or anything like that that could be affecting their A1C. Education follow-up, and that really is determined based on, you know, why I'm seeing the patient. So if I have someone that's newly diagnosed, I'm definitely going to be spending a lot more time with them, probably following up a couple times as compared to someone else, you know, that has an elevated A1C, and I might be seeing them every 2 to 3 days just to kind of figure out what's going on, reinforce information, and, you know, go over any different changes that we might be making to their medication at discharge. After I see the patient, I do work closely with case management. They're a huge asset to our patients, just making sure that the patient has appropriate follow-up care in a short period of time after discharge. If I have a patient we're starting new on insulin, you know, working with case management to check on coverage and costs to make sure that when the patient goes to the pharmacy to pick up that insulin, they know exactly what they're going to be paying for. And especially this time of year, a lot of our patients fall into the donut hole that are on Medicare. So trying to figure out all that ahead of time really is helpful. If their insurance, you know, their cost is going to be a couple $100s for insulin, then we need to come up with a better plan, something a little bit more affordable, maybe using Walmart insulin or something like that. And then lastly, one thing I wanted to highlight, this is a key asset that we have here at Mount Nittany, is our pharmacy glycemic control program. So providers can consult pharmacy for any patient here in the hospital to write insulin and diabetes medication orders and to adjust those orders as needed. So it's perfect for patients that are receiving steroids, perfect for patients with persistent high blood sugars, low blood sugars in the hospital, perfect for patients that come in a DKA or HHS that we might have on IV insulin infusions, and just the process of switching them back over to sub-Q insulin. And, you know, any of those patients that might be at high risk. They've been a really great asset lately with all of our COVID patients because of all the dexamethasone and all the stress that comes with that. They just have the time that they can kind of look at blood sugars over and over throughout the day and make changes as needed to keep blood sugars in a safe range and to help our patients get better. So I'm going to turn it back over to Susan.
Thanks, Heather. So as you can tell from Heather, we already had a really robust process for diabetes treatment and education. So when we started to focus on the combination of stroke and diabetes, I did reach out to Heather and the diabetes program to start the collaboration. One of the most important initial steps was to share the data that I already had on patients with stroke that I got from the Get With the Guidelines database. And I shared the total number of discharges with a stroke diagnosis and identified those that had a history of or a new diagnosis of type 2 diabetes. And I was also able to show the trends in diabetes diagnosis over time specific to our area. Another important step I took was to set up a meeting with our American Heart Association Director for Quality and Systems Improvement, who was able to answer specific questions that I had about the requirements for the Target Type 2 Diabetes Honor Roll. We use Meditech as our electronic medical record, and she was able to help with identification of documentation opportunities to help meet the requirements. We already had several steps in place prior to this initiative, including a comprehensive stroke education packet that already addressed diabetes. The stroke education packet is given to every patient who has the stroke order set used. And in 2019, the order set was used for just over 1,000 patients. Documentation of the specific education topic is built into the nursing work list, which is generated from the order set. At discharge, we have a template built for a hospitalist to use if they're discharging a patient with a stroke diagnosis. And on the slide, you can see a piece of the template that discusses risk factors for stroke, including diabetes. This is an example of more information that is in our stroke education packet about the individual risk factors, and we include a family stroke risk assessment. We also include general information about medications, which you can see on this slide, as well as other medication handouts for patient-specific medications that go into greater detail. But even if a patient with a stroke diagnosis does not have diabetes, they're still increasing their awareness of diabetes as a risk factor for stroke because we address it in so many different places. This is what is included in our stroke education packet regarding diet. Many of these foods and recommendations are included in a diabetes diet as well, and so this goes along nicely with any education that Heather would provide to patients. This also demonstrates how we include other health problems in our stroke education, such as hypertension, heart disease, and diabetes, and the lifestyle changes that can help. Looking forward, we plan to establish regular meetings with the diabetes and stroke programs, including setting goals and continuing to share data. The pandemic has sort of, put a hold on some of these meetings, so that is something that we're going to try to set up regularly in 2021. As part of our continuous evaluation of the stroke program, we plan on reviewing the discharge template for physicians and the stroke education packet to see if they're meeting the needs of patients and staff. We'd also like to explore methods to capture information on patients after discharge, such as medication compliance. We don't have the resources to make post-discharge phone calls to all patients with stroke, so we're going to look at what our EMR can do for us and to see what other community resources are out there. And lastly, we'd like to explore partnerships with community education. We, in our area, we have many great community organizations that we think can help continue the education that we provide in the hospital, and that will help enhance the continuum of care outside our hospital walls. Thank you very much for listening, and we'll be happy to answer any questions as time allows at the end.
Thank you, Susan and Heather, for that wonderful presentation and those excellent examples of really how to get started in the building blocks of a collaborative program. So it's now my pleasure to turn the presentation over to Melody Halio. Melody, the floor is yours.
Thank you so much, Renee. My name is Melody Halio. I am the nurse navigator for the Stroke and Diabetes program here at Henry Mayo Hospital. We're located in Southern California. And I'm going to talk a little bit about how we have created and changed our diabetes program into what it became today and how that really played into being able to achieve our target type 2 diabetes honor roll and create the best program we can for our patients. Okay, Robin. So I have no disclosures. So our hospital, Henry Mayo Newhall Hospital, we're located in Valencia, California. We're a 357-bed hospital. We're not for profit. We are a community hospital and trauma center, and we offer a wide range of services, including an acute rehab unit. We're an advanced primary stroke center. We have a spine and joint program, extensive cardiovascular services, robust community education program, which I'm going to talk about in a little bit, and many other services that we offer to our community. Our affiliated medical staff is comprised of many physicians, and their expertise range across more than 71 specialties and subspecialties. This is a picture of our hospital. We just opened this new patient tower last year. So some of the things I'm going to talk about for our diabetes program. We started the program back in 2015. And after identifying a need for more comprehensive diabetes care within our facility. So we originally constructed our program to have a nurse navigator overseeing the program and doing patient education. And we also hired a registered dietitian who is a certified diabetes educator to assist with the patient education portion as well. Over the years, that has changed a little bit. We do have a full-time nurse navigator overseeing the program. That's me. We have 2 dietitian certified diabetes educators supporting patient education, and we have one available Monday through Saturday, 8 hours a day for any organizational needs. We also have continued to educate the nurses on how they can educate their patients on off hours and Sundays when we're not available. And in 2018, the nurse navigator position was actually changed to not only oversee the diabetes program, but also happened to include the oversight of the stroke program, which was so very convenient for our No Diabetes by Heart program and the Honor Roll Award. Some of the challenges that came with collaborating with 2 programs was definitely time management, but it's been an incredible resource to be able to address the needs of those with combinations of cardiovascular disease, stroke, and diabetes. So this is us, just a quick overview. This is our 2 CDEs on the ends, our program manager and director, and they're also the critical care services manager director, second from left and third from left, and that's me, second from the right. So the goal of our program really was to provide comprehensive education in disease management to those with any form of diabetes, including insulin and non-insulin dependent prediabetes, gestational diabetes, and those with complications related to their diabetes process. So our program, what we did to identify patients who could benefit from our diabetes education or follow-up, we created a referral process. So any doctor, nurse, or dietitian could put in a referral if they saw a need. And this was very successful for the first couple years and allowed our diabetes educators and our nurse navigator to capture the patients who could use our assistance and education. The role of our CDEs has continued to evolve as well, so not just from patient education, but they're now assisting with discharge planning. They identify patients who might need further discharge planning, including new discharge medication education, a need for new insulin teaching if they're going to a pen versus a vial. We do provide glucose monitors for them if they need them, or provide information on how to get one based on their insurance needs. And they spend a lot of time speaking with the attending physician and the insurance company to ensure the patient has a safe and reasonable discharge plan. And so they almost become diabetes-specific case managers on top of it. So some of the areas that we identified for performance improvement for our program included follow-up care and education post-discharge, a more robust referral process, so we felt like we were missing some of the patients that might not get a referral, need for an interdisciplinary approach to our diabetes care, nurse-driven accountability in the care of our diabetes patients, so really getting those bedside nurses engaged and accountable for the care of these diabetes patients, because they're really the ones that are providing that direct care, and then a standardized evidence-based insulin dosing set. So our follow-up care and education post-discharge. So this was really an interesting topic because we had a community education program and it changed hands in leadership a couple years back, and they have continued to just take it above and beyond. It's really a robust program at this point, and we have free community education classes. They were previously in person or virtual, but now they are all gone to virtual since the COVID-19 pandemic. But we have an extensive list of follow-up classes for patients who are discharged or anyone in the community who would like to come find out about any of the information that we're offering. So every class in our community education program is free except for one, and I'm going to talk about that. It is open to anyone in the community, but we do really try to collaborate with them on post-discharge patients for all areas of care, but specifically for me, for diabetes and stroke patients. They also have 2 registered dietitians that are certified diabetes educators as well in the outpatient setting. So that has been a great collaboration for our diabetic patients. And we have been establishing follow-up care with them and trying to help them get registered for follow-up classes. They also teach many nutrition classes that are open to anyone, but also we really encourage our patients with diabetes to attend those. The one thing that we do have that does have a cost, which is our year-long diabetes prevention program. Those are for patients who have a hemoglobin A1C between 5.7 and 6.4. And the program has been nationally recognized for its success. So like I mentioned, it does have a cost associated, but the community education staff works with the patient's insurance to get the class covered, and almost all insurances do cover that class. We also print out the entire class list offered by community education as part of the discharge packet to all of the patients in the hospital. So when they get their discharge packet, they get a list of the community education classes. So this is what our community education, This is a little snippet of what the community education looks like. If you want to download the handout, you can see the entire handout. It's on a PDF there, but we offer a lot of classes from anywhere from body, brain health, lung health. There's multiple nutrition classes. We do offer a diabetes self-management class, which has been a great resource for patients wanting more information about their diabetes process. We have our CDEs identify patients that would be good to follow up with after discharge, and then the community education program helps them get enrolled for this diabetes self-management class. We also have a gestational diabetes class to support our mothers struggling with gestational diabetes. We have a stroke prevention class and a stroke support group. We have a lot of resources for our community, and they're all free. And so really the biggest challenge is getting it out there and letting people know all of the things that we have available. So not only are our educational classes offered, but we did recently add support groups for our diabetes patients. So in 2019, we created the Type Wonderful support group for our Type 1 patients and family members, and this has been very successful, especially in our juvenile, teenage, and early adult population. Their family members are coming with them and really learning and talking to other people who are going through similar processes and similar challenges in their life living with type 1 diabetes. It's been great for the parents of children that have just been diagnosed. It's been great for teenage going into early adulthood as they struggle to kind of manage their disease process on their own. And we've had tremendous success with this new support group. And we've now created a Type 2 support group, which is just getting up and running. And again, we have really been able to provide a place where people can come talk to others going through the same thing and be able to talk to others about their challenges. And especially virtually right now during the COVID-19 pandemic, it's been wonderful. So for our community education, I would say any robust community outreach and education process has really helped follow up after discharge and helped address the knowledge deficit, which is what we all know is a very common theme in patients with diabetes. So our referral process, one of the things that we identified that we could improve on was we were getting these referrals from the physicians and nurses, but we were still missing some patients who could utilize our help or some more education. What we created was called a conditions list, and just like Heather and Susan, we also utilize Meditech, and so it may go by a different name in the other systems, but we utilize Meditech, and we created what's called a conditions list. And what it does is it identifies all patients with keywords or lab values or any medications that you choose to put in as keywords to capture. So we built this conditions list to capture any certain keywords in doctor's notes or nursing notes, any lab values that we identified, any orders for insulin or hypoglycemic agents. So, and it brings up a list of every single patient that's actively in the hospital that meets any of these keywords. And then our diabetes educators are able to go through this list every morning and identify those who might be benefiting from more diabetes education or any follow-up care. So some of the keywords that we included, just for example, was diabetic ketoacidosis, any A1C greater than 7, hyperglycemia, any lab value with a glucose over 300, any ordered insulin, etc. There was a lot of of keywords and lab values that we pulled, but we created this, and it's been very successful in helping us identify and continue to identify all the patients that could possibly utilize our service. And as part of their routine, they check this report every single morning and go through the patients, and we were really able to broaden the scope of who we were capturing and what patients we could really help. So another area that we identified that could really help our program was an interdisciplinary approach to our diabetes care. And so what we did was we created a diabetes steering committee. It was a collaborative interdisciplinary committee that meets every single month, and it was created in 2018 to identify all the needs that we could address in one room at one time for our patients. So it consisted of our diabetes nurse navigator, which is myself, both of our certified diabetes educators, diabetes program manager and director. We had our endocrinologist, we had our clinical nurse managers for the nursing units, dietitians, we had some attending physicians, we had pharmacy, our medication safety officer, and then our chief nursing officer and chief medical officer were added as ad hoc. They would come in and check and see how we were doing. The other thing that we added was our community education team. So they were even part of our steering committee, and it has been tremendous help in getting that collaborative approach to processes and policies and protocols and so forth. So we've really had success in driving practice changes since initiating this steering committee, including our policy revisions. We've had a reduction in medication-induced hypoglycemia hospital-wide, and that's been a big focus that we've been looking at. And I'm going to talk a little bit more about that. Insulin administration practice changes and really focusing on how the nurses are giving their insulin and how we can keep our patients safe. And we've had many more projects that have continued to have a positive effect on our patient care. So some of the project highlights, we revised our critical care insulin drip process. It was old and a little bit out of date, so we brought that up to date with the newest and best evidence. We created an insulin pump policy, which we had not had at this hospital prior, including a waiver and the nursing process and documentation. We also made a new DKA protocol, as ours was old and out of date, again, with the most evidence-based processes up to date. And it was really a much better process to be able to address the needs of our DKA patients, who really are critically ill patients, but also to make it easier for the nurses to be able to follow the protocol, decrease any errors, and treat the patient appropriately. We also made an insulin administration policy, which is still in our hospital approval process, but it more comprehensively addresses all of our practices around the insulin administration, because we found that there was some unsafe practices happening around our insulin administration. And we really wanted to focus on having the nurses at the bedside really take charge and be accountable for these diabetes patients. So we really focused on driving diabetes care from the bedside nursing level up, from the ground up per se. I wanted to get the nurses involved and make sure that they had their suggestions heard, but also we made practice changes that made sense to them and made their work flow easier and not more difficult. Some of those projects included our insulin administration processes, our mealtime documentation, and just our general care of our patient with diabetes. One of the things that we realized was we had very inconsistent mealtime documentation, and on diabetes patients, we realized how important it was to make sure that they had accurate meal documentation showing how much they ate and what kind of diet they were on, and so on and so forth, so that the physicians could really go in and to make their changes to their insulin and glycemic agents, being able to identify how much the patient is eating, when the patient is eating, if the patient is refusing to eat, so on and so forth, because that's all important information when we're dosing our patients. Also, we made a change to the meal tray. So the cover of the meal, we changed the colors from the rest of the meals. And what that did was we realized the patients were getting their trays before the nurses were able to actually check the blood sugars, since they were supposed to be before meals. And so by changing the lid color, it gave the nurses the ability to make sure that they were checking the blood sugar and covering the patient with their insulin as needed once the meal tray was actually there and then the patient was able to eat. That little process change has made a huge impact on the way the nurses are actually caring for those diabetes patients or patients requiring blood sugar checks. Also, we really focused on nursing education and really getting them engaged in our program and what we were working on. And we really wanted to focus on improving their critical thinking at the bedside, because sometimes what we realize is insulin is given so frequently and we have so many patients with diabetes that it becomes kind of that routine automatic care. And we really wanted them to stop and think about what they were giving, why they were giving it, and how it might affect their patient. So this is just an example of one of our projects. We did this new project for meal documentation. If you can see, the first couple months, it was pretty flat around the 77th, 78th percentile. We started our measure in July of 2019, and as you can see, we've had pretty good improvement in this area, improved by over 7%. For fiscal year 20, we're about at 86%, and back in 2018, we had started around 76%. So we've made some improvement, and really, again, just trying to improve the care the patients are being provided by their entire diabetes team. Some other process improvements we made in nursing care included ensuring all the insulin is being administered within 30 minutes. So we realized sometimes the nurses were checking the blood sugar, the tray wasn't even at the bedside yet, and then they were covering a sliding scale insulin and the blood sugar was old, and we wanted to make sure the patients were getting their insulin dosed on a very accurate and recent blood glucose check. So we instituted this, making sure they were checked within 30 minutes. We also streamlined and tracked the treatment and documentation of hypoglycemia. We update our policy, we update our intervention where they're able to document, and just the whole process, and made it easier and more comprehensive. And then we really focused on nurse engagement. So what we did was I presented a lot at staff meetings. And then one of the biggest things that we did that got nurse engagement was we actually hosted quarterly pizza parties for the unit that had the best performance in our process improvement projects for that quarter. And we created unit-based diabetes champions to be resources to the nurses. So every unit would have 2 or 3 unit-based diabetes champions on day shift and night shift to be able to have the staff go to them and be their champion and kind of be the go-to between them and myself and the diabetes team. So this is another example of one of the changes we make: our insulin administration within 30 minutes of glucose testing. We were only doing that about 85%, and this was a pretty big number. We have, thousands and thousands of glucose checks happening every single month. So it was something that we really had to work with the staff to get them on board with. And so we've made a positive impact in that area, about 6% up since we started, and we're well over 90% now. And then lastly, we realized that all of our physicians were kind of dosing insulin in different ways. We didn't have a standardized evidence-based insulin dosing set, and so that was a big project that we rolled out a couple years back. So what we did was we focused on the dosing practices of medications, specifically insulin. We realized the hospital had a high rate of the medication-induced hypoglycemia, and there was no really standardized way that the physicians were treating these patients. So we created this, oh, I'm frozen. There we go. We created this order set in August of 2018. It has suggested insulin dosing based on the most up-to-date evidence. It has nursing orders, which were important specifically for glucose checks, hypoglycemic events. It had pre-checked orders for D50 and glucagon if needed to eliminate any delay of treatment for hypoglycemia, so that they had a protocol that they just treated it and then didn't have to wait for the doctor to call back and give them the order for the D50. We also created standardized sliding scales based on the total daily insulin requirements of the patient. So after rolling out this project, the team realized that we had this great insulin order set, but not that many physicians were always using it. So we continued to do some education and feedback to the physicians. And at this point, we now have about 97% utilization of our standardized insulin dosing set among the admitting and attending physicians. And really, it was educating them that they don't have to do exactly what our set is advising, but the most important part is utilizing the set for the pre-checked orders for hypoglycemia, and it gives them the guidelines to treat the patient the best as possible. And we've had really good success with that. So this is a picture of what our insulin order set looks like. As you can see in the red box, it has the suggested dosing, excuse me, the suggested dosing for basal insulin. It's considering to decrease from the total home dose. It also tells you if they're insulin naive patients, how you can kind of calculate that insulin for those patients. And again, this is just little suggestions. It's not something that's built, so it's not a forced order. You can also see above, we have our blood sugar checks, nursing orders for if the patient's NPO, and an automatic hemoglobin A1C ordered if it hasn't been done previously. So it also had our standardized sliding scales, and it actually guided them how to pick if they wanted a mild, moderate, or resistant sliding scale based on the patient's total daily insulin dose. And you can see that kind of guided them on how to pick a sliding scale. And then lastly, down at the bottom, this is our HS sliding scale, which is always a mild unless they want something specific, and an automatic order for the hypoglycemia protocol, so that the nurses have that protocol established on their medication list and their nursing list. So with this order set and the other projects that we worked on, we were able to get a 45% reduction in our total hypoglycemic events caused by medication in the hospital in the last 3 years. We start out at over 1,500 events. We're down to 853 for the fiscal year of 2020. And we really just wanted to make sure that while we were treating our patients well and making sure we were reducing their blood sugars, we also weren't causing any patient harm by over-treating them. And so we were able to really focus on that. And we decreased the incidence of hypoglycemic episodes caused by our medication administration in the hospital by 45%. And it really helped with keeping our patients safe. So in terms of our target type 2 diabetes honor roll, we were very fortunate because it was so closely related to the stroke program, which I just happened to also be over. And having a nurse navigator over both programs was definitely an advantage. Most of the criteria that was being captured was these patients who were already stroke patients that we were already looking at, but they also had that co-diagnosis of the type 2 diabetes. And so what we were doing with when we got this rollout of this project is making sure that we addressed each fallout. So we have, this was being done within our stroke program as it was, and so we just had to focus more on this subset of our type 2 diabetes patients. But each fallout within our stroke program, and now within our diabetes patients as well, is individually addressed with the physician. So we have a medical director that will talk to the doctors if there's a fallout, or I talk to the nurses if it's a nursing fallout, or either one of us, preferably face-to-face, but we also utilize email if needed. Also, if there's a trend identified, we bring it to the attention of the stroke steering committee. So every month we also have a stroke committee. We review any fallouts and we identify any areas requiring performance improvement or any areas that we're doing well in, and then we create a plan of action and report back to the steering committee once it's addressed. We also track each fallout on our dashboard and report it out to the steering committee, and any common fallouts or areas for improvement are also presented 2 to 3 times a year at multiple medical staff committees as well. So in terms of the diabetes treatment measure, so this was the one area that was new that wasn't normally addressed from the previous stroke measures. It was the percent of diabetic patients or newly diagnosed diabetics receiving diabetes treatment in the form of glycemic control or follow-up appointment. So we really had to get some physician buy-in for this measure. We already had a lot of physicians that were really focused on the diabetes program, and they knew how hard we had been working on all of this. And so we did have to get more buy-in in terms of this measure. What was happening was we were having a lot of physicians documenting just follow-up with primary care regarding new diagnosis of diabetes, which was fine, but then they weren't actually setting up an appointment for them. And so we worked on that portion of it to really either get them on a new discharge routine with some sort of diabetic medication, or at least have a date and time set for their scheduled discharge treatment. So other than that, we discovered that all the measures were already being addressed almost 100% of the time from all the work we've done within the stroke program and the continued work within the diabetes program, and just anything that needed a little further education on that measure was provided directly to the physicians. So looking ahead, we've really been focusing on reducing patient harm from medication-induced hypoglycemia, but now the program is moving forward with really focusing on our hyperglycemia as well, concurrently, so that we can make sure we're not having out of control one way or the other. We are rewriting our definitions because CMS had recently put out some suggested guidelines for tracking this data for hyperglycemia, hypoglycemia, and severe hypoglycemia, and it would be, we're rewriting our definitions to really allow the hospital to better evaluate our quality of care, but also to potentially be able to benchmark with other facilities. Other projects on the horizon, we're working on safe IV push insulin administration for hyperkalemia, the practice around that process. We are doing a gap analysis to potentially apply for Joint Commission certification in disease-specific care in diabetes, and increasing the utilization of our referral process and continuing to bridge the gap so that patients can utilize our community education program even more and continue staff education and awareness. So recommendations from our program, what's really helped us make us successful in achieving our award and our patient satisfaction levels, was creating our interdisciplinary committee, our standardized insulin order set. I really do encourage you to utilize that if you don't have one, and the physicians just absolutely love it. Nursing care orders, and really making sure that our patients are all kind of getting that standardized care within their diabetes disease process, and making sure we're kind of treating them with similar protocols, but addressing their patient-specific needs at the same time. Also, just making sure you have that collaboration, which can be really challenging depending on your hospital and your physicians. Making sure you have that collaboration between your physicians, and making sure you have that collaboration between your nurses. So just listening to the barriers and challenges, following through, and getting the buy-in from both of those teams. And that is all I have for you. Please feel free to ask any questions in the comment section, and I appreciate your time.
Thank you, Melody, and thank you so much to all of our presenters for leading today's webinar. We would now like to move over to the Q&A session. I'd like to introduce my colleague, Liz Olson, who is a Senior Quality Programs Manager, who will lead today's session. And again, you can still submit questions for our presenters through the questions pane in your attendee control panel. Liz, go ahead with the first question.
Great, thank you. The first question is for Melody. A significant number of stroke patients present with a previously unknown elevated hemoglobin A1C and then a new diabetes diagnosis. Do you have any strategies for teaching these patients who may be in an information overload? And do you have them all follow up with endocrinology?
Hi, thanks for your question. So this is Melody. So we don't have every patient follow up with endocrinology. It's kind of based on the admitting physician preference, depending on how bad their diabetes was, what level their A1C was. But no, they are not all followed up with endocrinology in-house, but they are referred to endocrinology outside for follow-up. We refer them to an endocrinologist once they're discharged. In terms of these stroke patients that come in, it is definitely some information overload. And actually, just like Susan and Heather, we have a stroke education packet that has specific sections for all the different disease processes that may be contributing. And what we do is we have our nurses go through and talk to them and kind of highlight on the table of contents what areas are applicable to those specific patients, so that they can take this booklet home and go through that information too once they get out of the hospital, as definitely it's a lot of information coming in from the hospital. And anybody who is a new diagnosis, we have our diabetes educators go talk to them as well and provide information in the form of handouts. And lastly, we do refer them to our community education class so that they can kind of follow up. Our diabetes self-management class is really helpful for those newly diagnosed patients so that they can get some information once they've settled down, gotten discharged, kind of processed everything, and then they can continue their education at the community education center.
Great, thank you. Similar question for Susan and Heather. Do you have any programs that you can talk about that educate diabetic patients on stroke prevention and awareness for primary prevention of stroke?
Hi, this is Susan. So we, one of the things we struggle with is once patients leave the hospital, what sort of community education can we give them? So one of the things we have started to do as a stroke program is we partnered with a local stroke certified rehabilitation center to host some stroke support groups. And so in those, we did address some of the risk factors for stroke, including diabetes, and we did discuss the therapeutic lifestyle recommendations. When it comes to in the hospital, that's one of the things that I would love to focus on for next year is how do we, how can we collaborate and partner even more with diabetes to help people understand the connection between those two diagnoses. So that's a goal of ours.
Thank you. For Heather, regarding the 30% reduction in medication-induced hypoglycemia, first of all, congratulations. Do you know which medications contributed specifically, or can you speak to that, that contributed to the hypoglycemia? And there are a few other follow-up questions here, happy to repeat it, but also curious what percentage were attributable to sulfonylureas, and can you talk about the process to pull this data out and perhaps how difficult it was?
I think that's for Melody.
Melody, if you'd like, I can repeat the question. So the question again was, can we speak to which medications contributed to hypoglycemia and what percent were attributable to sulfonylureas?
Oh, perfect. Thank you. Sorry about that. So we didn't pull specific medications in terms of what was contributing to the hypoglycemia. What we were focusing on, we actually tell the physicians that we prefer no oral hypoglycemics within the hospital. And so what we really focused on in terms of decreasing that hypoglycemia was insulin care. So when it came to our hypoglycemia reduction, it was within the hospital, from the medications that we were giving within the hospital, not what was being given outside. And we did not pull specifically on any oral anti-glycemic agents.
Great. Well, thank you. I see we're at the top of the hour, Renee, so I'll turn that back over to you.
Thank you, Liz, and thank you so much to all of our attendees who submitted those excellent questions. And we do have a record of those questions, so we'll try and make sure that we get the questions answered that we didn't have time for today. I'd like to thank our presenters for leading today's webinar. Thank you, Heather, Susan, and Melody, and to thank all of you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey, and we'd appreciate it if you can complete that and provide your feedback. In that email, you'll also receive a link to view a recording of today's presentation. On behalf of the American Heart Association and our presenters, thank you for joining us and have a great day and a wonderful holiday. This concludes today's presentation.